So good evening to one and all, and at the outside I would like to thank Professor G.V.K. Sir for the opportunity. Good evening, sirs. So stroke is such a common ubiquitous problem, especially when you have a hospital. You will definitely encounter at least 2 or 3 strokes in a week. Such is the presentation nowadays, and it's going to be a real big issue nowadays. So the prevalence of, global prevalence of diabetes is ever increasing. You all seen that it's almost from in 2010 it was predicted to be around 285 million. It's about in 2030 it's 439 million people. It's 54% increase in the population. And more importantly, it affects the underdeveloped countries and growing countries, where the 69% increase is happening in countries like India and Asian countries. So also the stroke. So when this is increasing, the stroke is also going to increase. So it's multifold, and you can see due to diabetes, there's a lot of changes happening. It's purely an inflammatory disease, and it's also called popularly known as vasculopathy. Diabetes is a vasculopathy. So there's vascular involvement happening, and through the systemic inflammation and arterial stiffness, and also due to the various modifications happening in endothelial dysfunction, all these causes the atherosclerosis. That atherosclerosis leads on to stroke. And today's topic is what is the pattern that you get. It's very, very typical of diabetes. So diabetes is an independent risk factor of in developing stroke, and diabetes is an important independent risk factor. So when there is diabetes, when compared to non-diabetic patients, there is 2 to 3-fold increase in stroke presentation. And most common form of presentation is ischemic stroke. And when compared to hemorrhagic stroke, ischemic stroke is more 3 to 4 times common. And it also, the risk is more when there's concomitant illness like hypertension, myocardial infarction, dyslipidemia. And of course, even in pre-diabetic patients, we see it's happening. So what are the factors in type 2 diabetes predicting an increased stroke risk? So the proteinuria, the odds ratio is 3.23. Systolic hypertension, blood pressure has gone up, and the high diastolic BP. If the fasting sugar is more than 200, A1C more than 9.5. Of course, hyperuricemia. As the aging population, age above 60, the hazard ratio is much more when compared to those below 60. And of course, the women, the risk of stroke in women is quite high. So there's a huge meta-analysis of 64 cohort studies from 1966 to 2013. The pooled data clearly says there's 2.3% risk ratio in women and compared to 1.8 in men. So it's a relative risk actually. Compared with men in type 2 diabetes, women with type 2 diabetes had a 27% greater risk of stroke. That's a study from Lancet, and also 37% greater risk of stroke in type 1 diabetic patients. As stroke patterns, as I told you, the most important, most common form of stroke is ischemic stroke. Hemorrhagic is slightly less common, and predominantly it is lacunar infarcts. Dr. Arun was talking about dementia. You see the lacunar infarcts is the main cause of dementia in diabetic patients apart from the hyperglycemia per se. So you can see the chart here. There is a more incidence of low lacunar infarct, and hazard ratio is 2.35 with a p-value of 0.001, and that is a thing about diabetes. So association of lacunar stroke, which is more common when compared to large artery atherosclerosis or cardioembolic stroke, which is relatively less. Cardioembolic stroke is not directly due to hyperglycemia. It may be due to the concomitant illnesses. It's only a diagrammatic representation. What are the clinical clues suggesting diabetic stroke? So the clinical, you may not, actually patient may not present exactly with the stroke to start with. They may come with some dementia like. So if you find recurrent lacunar syndromes, they are the one to go for a big stroke. And of course, it's stepwise neurological deficits, much more common. It's more evolutionary in diabetic patients. And of course, with the history of long-standing diabetes with comorbidities and complications, the stroke is going to be ever increasing. What are the clinical stroke patterns, syndromes in diabetes? One is lacunar syndromes, that's present as purely motor hemiparesis. It can be a sensory stroke, it can be ataxic hemiparesis, and more commonly, the posterior circulation stroke is actually thought to be, it's proved to be more common and it's more dangerous, and mortality is very, very high. And it can be present as dysarthria. There's a cognitive decline. That's equal to vascular dementia, which was nicely stated by Dr. Arun. Often subclinical silent strokes, and the most important is the recovery is poor, and there's a higher reoccurrence rates as far as the diabetes is concerned. The white matter disease and cognitive impact, again, the leukocytosis is common among long-standing diabetic patients, and it correlates with executive dysfunction, gait disturbance, slowed processing speed. Sometimes they are taken as Parkinson's syndrome, and they also present like that. And major contributor is a vascular cognitive impairment, often clinically very, very silent to start with. Of course, the silent brain infarctions are very common in diabetic patients. It's 2 to 3 times higher than the non-diabetics. Typically, the lacunar infarcts detected incidentally on MRI, not of course, the predictors are futures. They really predict about the future symptomatic stroke, and there's a cognitive decline and often associated with the white matter disease. The cardioembolic stroke, which happens in diabetes, is a little bit circumlocutus, where it doesn't directly involve. Due to diabetic cardiomyopathy, due to microangiopathy, patient develop LV dysfunction and increased prevalence of atrial fibrillation, which in turn leads on to embolic formation and leads on to cardioembolic stroke. The hemorrhagic stroke also is there in diabetes, of course less common. It's the mechanism in microangiopathy and chronic hypertension. The common sites are basal ganglia, thalamus and pons. Of course, worse outcomes are there as far as diabetic patients when compared to non-diabetics. Neuroimaging patterns, you can see the lacunar infarcts, internal capsule, thalamus and basal ganglia and pons. Leukocytosis is always there. Multiple silent infarcts are common. Cortical infarcts are there due to cardioembolism, and diffuse brain atrophy in long-standing diabetic patients. Stroke mimics are very, very important. This is very essential. It's a very important slide. Hypoglycemia. Many a times patients do come with a stroke, and just do a simple blood glucose examination, you can completely avoid the whole problem, and that's very essential. So hypoglycemia per se can present as a stroke. Even hyperglycemia can sometimes present seizures and encephalopathy, and acute onset once almost mimicking like a stroke. So these two are very essential, got to really understand. And diabetic neuropathy may confuse localization, and of course we have to constantly correlate clinically, and imaging has to be done, and then only can clearly treat. And most important, prognosis and recovery. And the highest readmission rates happen in diabetic patients, no doubt about it. Poor functional outcomes, you'll always see the functional outcomes are very poor, and the greater risk of occurrence, and the large infarcts are very, very common in diabetic patients. And most importantly, hyperglycemia during an acute phase increases the mortality in diabetic patients. So you have to prognosticate with each and every patient. Of course, not the less, you got to prevent the stroke. Usual things of the exercise, the dietary, lifestyle modification, good glycemic control are the cornerstones. And stroke prevention, the multifactorial, and you need to involve the patients properly. And of course, treatment, we can normally during acute phase, we give insulin to the patient. Better to keep the blood sugars around 180 rather than bring it down. That itself can cause sometimes the worsening of the stroke. And sulfonylureas actually thought to be reduce the hemorrhagic transformation. TSDs have been proven. You have seen the proactive trial where they have shown reduced stroke incidence, and of course in IRIS trial also they are proved, and that's very important. Of course, lipid control is the most important step that happens right from the word go, and above 40-50 years with 1 or 2 risk factors, you have to start on lipids. And conclusion, diabetes, all accept, diabetes is a strong modifiable risk factor for stroke. It nearly doubles, triples, especially for ischemic stroke. Lacunar infarcts are so undetectable, it's so commonly presenting inside, and we don't know, and that can cause lately large atherosclerotic stroke. And diabetes causes endothelial dysfunction, inflammation, and arterial stiffness. These changes promote atherosclerosis and vascular damage. And you have seen after COVID, there is more and more incidence of vascular events happening. That's also an inflammation is the main cause. And with the pollution and all those things happening in our country, the stroke incidence is quite common. And our burden is much worse In India, we've got young people who are becoming diabetics nowadays. We see 35, 40 year stroke patients coming to our hospitals. So high glucose is a thing that worsens outcomes, and target glucose in acute stroke, better to keep it around 140 to 180. And stroke prevention requires multifactorial control and not glucose alone. Finally, it's control of BP, lipids, and lifestyle along with glycemia. All these things will definitely prevent the stroke. Thanks for the opportunity. Thank you.